My name is Peter Schneider. I'm a vascular surgeon in San Francisco. I'm here at PVI 2025 here at Carousel du Louvre in Paris. And earlier today, we had a very robust and exciting session on treatment of carotid artery disease. And of course, this is an area of high interest to many of us who treat patients with extracranial cerebrovascular disease. And it's also an area in which there's been a real explosion over the past couple of years of new data, new trials, new technologies, and new techniques. Today, I spoke about the use of TCAR or transcarotid artery revascularization to treat patients that we worry about most, such as those who've had recent symptoms, and also patients who have a presenting problem of a contralateral carotid artery occlusion. We know from many years of treating these patients with other modalities such as CEA or transfemoral stenting that these are quite high risk categories or subgroups of patients. And so my task today was to summarize the most recent data and talk about some of the nuances of treating these two groups. When I refer to TCAR, what I'm talking about is a direct carotid access to the common carotid artery, and then quite a sizable flow circuit that's connected to a 6 French sheath in the femoral vein. And the combination of this provides relatively robust flow reversal. So one of the principal features, besides the fact that we talked about this high risk subgroups of patients, is that flow reversal provides very robust flow during carotid stenting. And of course, the challenge with carotid stenting always, no matter how it's done, is how to remove the particulate that has been generated during the time of lesion manipulation and stent placement. So with TCAR studies that have been done primarily in the United States, I was able to cite some data that's accumulated over the past couple of years. Probably the most important data sources come from the Vascular Quality Initiative, which has now folded into another huge database, the National Cardiovascular Disease Registry, NCDR. And the combination of these databases have approximately 150,000 TCAR cases within it. About 10 or 12% of those do have contralateral carotid artery occlusion. And the data show that the patients do just as well, possibly even slightly better than having a CEA in that setting. With respect to patients with recent symptoms, there has been a real push in the US, mostly following our European colleagues who have identified the time frame of anywhere from 2 days to 14 days following a recent stroke. So these recently symptomatic patients, we worry about them because these are friable lesions that are more likely to embolize when being manipulated. So TCAR does provide very robust protection during that time because of the flow reversal. And the latest data that we have actually come from the VQI in the timeframe since the approval of carotid stenting by US regulators to be on relatively equal footing with transfemoral stenting and with CEA. And what it shows is actually a benefit to TCAR when it's compared to transfemoral stenting, and approximately the same or similar to CEA in these patients with recent presentation with stroke. Again, we try to operate greater than 48 hours and before 2 weeks. And I think this is becoming now a worldwide standard. And we're able to show in, again, many thousands of TCAR cases that have accumulated that this is a safe approach to use it in that setting. So thank you very much. This has just been a fantastic program so far. It's early on, but the first day has really been wonderful. Thanks.